Yeah, today's topic is upper respiratory tract infection. Maybe I think so you got the idea before.
Sound is not.
No, sound is not coming. No, that's okay.
Not loud now.
Loudspeaker is not on.
Yeah, we got it.
No? Yes, coming? Okay. So, to introduce the upper respiratory tract infection, I think so most commonly it is the nose, nasopharynx, and the oropharynx, laryngopharynx, and upper part of the trachea. We generally take it that way. So, the common respiratory tract, upper respiratory tract infections, what we see is rhinitis, the rhinosinusitis, which I have told you just now, nasopharyngitis, pharyngitis with epiglottitis, laryngitis, and laryngotracheitis with tracheitis. So, I feel the most dangerous could be epiglottitis, so where there is a risk of sudden death or sudden obstruction to the respiratory pathway. The most common OPD patients we see is upper respiratory tract infections, which are more than 40% in the OPD, and patient lose most of their time from the work or school is because of URTI. Then we have different, upper respiratory tract infections. It could be allergy, it could be viral, it could be influenza, bacterial. So how to differentiate these is if there is allergy and watery discharge from the nose, what we commonly ask the patient whether the hanky is starchy or not. If it is not starchy, generally it will be allergy. If it is going to be a starchy hanky, then generally it will be viral or bacterial. So it's very easy to diagnose that way. And the other common things to differentiate is whether in influenza you have this malaise and fatigue, headache, which are very common, and whereas the allergy will be never ending. It's most of the time seasonal or perennial, and whereas in viral self-limiting, and whereas in the influenza you will have for a longer time sometimes. And these influenza and virus, bacteria is mostly with the immunocompromised or with diabetic, they are more prone, or children or elderly people I have seen. There is a gonococcal pharyngitis. This is a small slide which showing petechiae, which in the soft palate, with tonsils also being inflamed. This is epiglottitis, which I just told you, you will have a muffled voice like a potato voice, no? There's a potato inside, and then you'll have the cough. And I will always say that the doctor not to do a tongue depressor, examination with this patient. They can generally go in for respiratory obstruction. So it's always better if you suspect epiglottitis, never to put the tongue depressor in these cases. Because you can always see there will be drooling of saliva, that potato-like feeling in the throat. And mostly they are children, but adults are also there. Most of them, it is children who suffer most epiglottitis. Laryngotracheitis again is you have the symptoms of hoarseness of voice is very common, and dry brassy cough, or it could be inspiratory whooping cough, which can be present. And in children, this long duration hacking cough will be always there. The cause in most of the viruses is generally rhinovirus. You have adenovirus, Coxsackie virus, and in case of influenza, you have this bacteria, Streptococcus pneumonia, which is most common, 30 to 66%, and Moraxella is another one, and the Haemophilus influenza is the other one, third one. So the risk factors I have told you, generally it's a contact from one patient to the other, or immunocompromised patient or diabetic, most of the patients, or smoking carriers, which are mostly adults or elderly people. So what are the investigations you would like to do? For virus, I think we don't go for any investigation because every time the virus changes its own their mutation keeps taking place. So whereas for a streptococcal, you can go by that. Blood culture, other tests are there, swab test. So these tests you can keep doing them. Then there's a 5-point decision rule where you can warrant high antibiotic or intermediate score where you have this culture test and a rapid test, immediately you can do. Where there is a low score, antibiotics are not required. So for group A streptococci, the specificity is very excellent, but sensitivity not correct, or it may be imperfect, and the yield results are within 10 to 20 minutes. You can obtain a culture which has a greater sensitivity and can do a rapid antigen detection test. Whereas in the sinuses, can go for a puncture aspirate where there are cases where fungal ball is there, other complications with diabetics. You can always go for a further surgery instead of waiting for the infection to subside, because it keeps repeating in these patients. These are very separative diseases. So in resistant cases, it's always better to go for surgery in where maxillary sinuses or sphenoid sinus or ethmoid sinus are involved. Treatment is generally symptomatic, whereas in allergy, I think so, most of them you give the antihistamine. Nowadays you try montelukast, and with Flucort or in children, mometazone sprays are given. Whereas in viral symptomatic like analgesics, antihistamine, few prophylactic antibiotic can be given. Whereas in bacterial, antibiotics are required. So again, the treatment for streptococcal pharyngitis, bacterial sinusitis, epiglottitis, you have to give a specific antibiotic, which is higher generation antibiotics to be given. In diphtheria, if it is proved, then antitoxin to be given. Antivirals do not provide any clinical benefits, so we hardly use any kind of antiviral drugs. Most common antibiotics which we used in streptococcal infections are amoxicillin or amoxicillin with clavulanic acid, azithromycin, cefalexin, cefuroxime, and in cases of epiglottitis, higher generation like cefuroxime, cefuroxime with sulbactam you can try in IV doses. Then this hacking dry cough, which is pertussis, you can give them azithromycin. This macrolides and clarithromycin. The analgesic treatment we give is paracetamol, acetaminophen, and anticholinergic to keep the dryness. You can give a local hypertropium local application. And antihistamines, we have the latest generation like fexofenadine, which we use really now most commonly, and levocetirizine. These are the older drugs, but now it's not used much. Whereas antitussive, you have nowadays this guaifenesin, which is most commonly used with dextromethorphan. Steroids required in cases where there is sinus ostiums are blocked or there is edema in the vocal cords or the larynx part. So we have to give steroids in those cases where there is laryngitis, where generally, it is short course where steroid is required. and decongestants like oxymetazoline, which is commonly used nowadays, can be tried out for the nasal block. And in cases of study with amoxicillin and other antibiotics, they have found that the results I'll show you here. This, you can see that sensitivity is very good for the amoxicillin with clavulanic acid. Then again another study which is showing, which has been done with the treatment of amoxicillin with clavulinate. There is good, excellent results. You can see with placebo and almost 51% after 10 days of treatment. Again, one more study with this. Study 3. This is again to compare with the cefinidine with amoxicillin and clavulinate. And here again the results are good with the amoxicillin clavulinate. 10 days when you give the treatment, you can see it almost goes up to 94.9%. So most of the bacterial infection like streptococcal pyogenes are eradicated by amoxicillin clavulanic acid. So in summary, URTI is a common cause for frequent OPD visit of patients. Viral infection is the major cause of URTI. It's important to differentiate between allergic, and viral and bacterial. Very important. Antibiotics should be used appropriately for the treatment of URTI. 5-point decision rule may be useful, and in the survey we have found that amoxicillin and clavulanic acid has been very effective in acute otitis media as well as URTI. This is tonsillitis, what we see, as compared to cefinidine and azithromycin. Thank you. Okay, thank you.
Question.
Any questions?
What are the 5-point decisions? Some 5-point.
5-point rule is that is you have to see whether the patient, how one is the nasal congestion is there, fever is there, and the malaise, headache, all this kind of those 5-point rule we make it. If these are there, then this antibiotic can be tried on them and your signs, whether the inflammation, this petechiae which I have told you all this, they will be in the on examination of the things, on your clinical examination.
What's the rapid antigen strep test? I haven't seen that here in India.
We hardly do, it's only for the academic thing, but rapid antigen.
But it was done in the US, commonly in the
Normally done, but we here, I have not done in my hospital nor in my,
Okay, so I just want
where my clinic is there, I don't do this test.
Okay.
This is only for the purpose. I think so in states,
They do
maybe,
it all
as you
the
are saying,
time.
they are doing
It's
a
very
fast
useful.
rapid antigen antibody test. But we are not doing here. It's real I mean, it's good, but I think it works out more expensive and then time consuming and all that.
I have one question. Sir, I agree with you that amoxicillin is a good drug for treatment of upper respiratory infections in children less than 5 years of age. For children more than 5 years of age and for adults, mycoplasma pneumonia is a common cause of URTI. So how do you perceive amoxicillin in the treatment of children more than 5 years and adults versus azithromycin?
About 5 years, if you feel that it's a bacterial infection, you can give along with that azithromycin, as you said.
So if you want to prefer among amoxicillin with azithromycin, would you prefer azithromycin for this?
Yeah, you can give combination. If you are suspecting pneumonia, use a streptococcal pneumonia. I mean, mycoplasma pneumonia. If you are suspecting that, then. But these are all atypical bacteria. These macrolides are very good in atypical pneumonia, not in commonly used pneumonia.
In your slide, you also listed pertussis. I thought it was not very common. Do you still see cases of?
We don't get many cases of pertussis. as per se. It may be with the pediatrician they have, but if it is a long standing and then, you know, I mean, if it is there, then it's quite, you know, has to be treated in a emergency way, and you know, you have to see the child is treated as early as possible. And to be diagnosed also is to be there. Pertussis cannot be. There is a child coming just with a hacking cough or dry cough. You can't tell that is a pertussis.
Thank you.
How good is the vaccine vaccination, flu vaccination in general practice? Should we recommend, when should we recommend that they take the vaccine this flu vaccination, and when does it the change the virus virus changes, and when is the new batch comes? When does the new batch they manufacture?
We have not been trying, but only the latest these Palmigen and other drugs with
Vaccine is generally
pills are there.
people are
That is
taking.
only for patients who get recurrent bacterial infection in this lower respiratory tract, not for upper respiratory tract. I don't think we have any kind of vaccination.
That's for lower
If the
respiratory
lower respiratory tract, we have some vaccination, but not for upper respiratory tract, because the mutation is so fast, and every time there will be a different virus. So we can't, you know, have a specific or a general vaccine for upper respiratory tract thing.
Above
I haven't
65
tried
and
it
below
so
5
far.
years is
But for
one.
lower respiratory tract, they have recently come out. That is 10-day course for 3 months every year. That is Palmigen, and there is one more.
Vaxigrip we are using. Vaxigrip is one of the.
Vaxigrip for something for lower respiratory tract. But that is very common. I mean, now there is from past 3-4 years, or it has started in states, again it has come here. The same
It's
thing.
usually
was
always
known.
retrospective. Sir. When they get the antigen of this year, they usually prepare the same for the next year. But if it's already and the virus has changed the antigen, so they may not be effective for that year actually. And any child who more than 6 months of age, you can take the vaccine. But it's usually preferred for only preterm babies or some debilitated patients or some patients who have chronic respiratory or cardiac illness.
For URTI, I don't think right now we have any kind of vaccine.
This one of the other widely publicized, it's a pneumococcal vaccination, which is given above 65 and below 5 years of age for the
For bacterial.
Yes, for bacterial.
Not for viral.
For low respiratory.
Yeah, this,
Maybe
that
for
is-
bacterial, but
But people here, they are coming and asking for the Vaxigrip vaccination. So we were not sure when to give them and how much to tell them that it will prevent them from what. Usually it's the H1N1 flu vaccination it comes with, H1N1 and influenza,
nothing but flu
and I think it's a viral. That's what they manufacture.
Recommend for everyone, sir. Only those who have supposed to have a severe.
also contact with those people like H1N1 group. Now, we can't give everyone. Maybe expensive also. I have no idea about it.
I will.
But those who are having contact with H1N1, then I think so they can go for vaccination.
Sir,
That may be
pardon me,
Contact
I'll
wise
take
it
the
won't
question.
prevent, sir, actually. Because there is a short period actually after the contact between the incubation. Take the vaccine at that point of time, it won't prevent.
Won't prevent, but still you can.
If you really want to prevent,
maybe
hemoglobin is a better one, sir. at this point of time.
the intensity of the disease may not be that much also. It may come down. That's another thing we can do.
Yeah, Dr. Vijaya wanted to say.
Yes.
See, I practiced in the US for some years, so I know what this vaccine. In the US, they're giving the flu shot to everybody after September. September to December is the flu season there. So irrespective of the age group, they're giving pediatric and adult. Everyone gets flu shot every year. And for pneumonia vaccine, they give it compulsorily to COPD, chronic renal disease, dialysis patients once in every
Diabetic
10 years. And if they have cystic fibrosis and some other serious respiratory infections, they give the pneumonia vaccine every 5 years. So that's the schedule they follow.
Actually, it all depends on the affordability of the country, sir, madam. Actually, in
Here, I
US,
don't
all the
think we
options
are doing anything of that.
No, but we can always offer. Because it's
Yeah, of course.
available and
You can
all
offer the
patients,
patient.
we are able to afford.
Definitely.
So all 65 and above, I give a Pneumo 23 definitely to
yes.
them.
How expensive is it?
And if they get
That's 3,000.
No, no.
3,000.
3,000.
The flu vaccine is only 600 rupees.
Yeah.
And that's Sanofi and it's Vaxigrip.
Vaccine. But the only problem is our flu season starts in June, July.
No, but we still haven't gotten the new one.
No, that's probably the Americans bring in September.
But
if we
this
give in October,
August and September, you have generally the adenovirus which causes ear infection. You will see most of the children with ear pain and adults also, some of them. This is a very common season for August and September. You can see more number of cases compared to the other months.
but there's an MNC close by next to our location, and they give the flu vaccine every year, and they found a tremendous reduction in the number of URTIs,
So they have
flu vaccines.
So and it's even
I think
like
we can
They usually give in September, October, whenever the American batch gives.
Acha.
And I usually take my flu shot in April.
so which is the same one?
I take the same thing I take in April because our first flu season is in
Yeah.
August, July, August, September, and it has helped me a lot. My number
Yeah,
of
those who
antibiotics
are
have
like
come down.
susceptible, like diabetic, smokers,
But Dr. Vijay,
old
take
age,
it
old
as a-
elderly,
like, I'm gonna
they can
declare-
definitely, children, they can definitely go for it.
So I think
This
it's
kind of, I mean, but you are saying for everyone, then
Yeah,
it will
for
be a
everyone.
big thing, no?
Yeah.
The kind of production what they need for that drug to be, but what is the cost of that?
600 rupees.
600 rupees.
Not much, but still.
The
I
treatment
think
costs
so.
200 rupees.
Treatment cost will cost more to consultation plus
Yes, yes,
Plus lab
states
testing.
is compulsory for everyone to
Maybe
take.
you-
If you said 250 million people there, you have to give 250 million shots. So that way, in India it will be almost, 125 million here.
No, that's true, but for pertaining to this particular
No, 1,000
thing,
million,
Chadda,
1,000
we can use
million.
it, yeah.
Something like that. So many shots is compulsory viral. Why? I mean, it's quite. I mean, those who are very sensitive, that they feel that they have to have a prevention. But after taking that, do you feel that you don't get the viral cold?
Yes, I found that too.
No, my personal feeling for myself is your cough and cold, which is very bad and which can sometimes last for 7 days, it shortens. It's not that you won't get cough and cold. You will get cold, you might get some sore throat, some cough. But the symptoms are not as bad as it is without the vaccination.
Possible, but you will still get it, I think. So.
Yeah, of course you can. It will not be very bad. That's all. And you won't get H1N1. That's the most important thing.
That maybe, I don't know. You are very sure you won't get H1N1.
No,
That
Yeah, with this you'll not get.
Definitely it won't get.
Won't get.
Because it's the
600.
only there's antigenic shift is there suddenly and they may still get it. But at least for that antigen, the same mutation, there won't be any.
For that mutation. But with a different mutation, you'll get it.
Yeah, if it's a new mutation like what happened in Mexico, something new happens, then this may not work. Then there'll be some H9N1 or 10N10 or whatever.
That's a good thing. You can, but education is more important in India. I think so if that is there, awareness with the patient, then it's a good idea to give everyone.
No, so here in this
So
clinic we have a lot of patients.
then you have to have a lot of paramedical staff to do this that way. I mean that way it's good, but the kind of the population we have, it's
Yeah, you're right. It's very hard to give it as a general. Here we use it.
because
as-
doctor themselves cannot do this. Only the paramedical staff can do that.
Good evening, everyone. I was taking on approach to a newly diagnosed diabetic. To start the case, a 58 years old gentleman who underwent routine health check. His fasting plasma glucose is 90 mg per deciliter and a postprandial blood glucose of 158, and his glycated hemoglobin is 5.8%. The two questions arise out of this case. One is what is his diagnosis and how to manage this patient. So coming to the definitions of diabetes and pre-diabetes. Pre-diabetes is defined as it's basically divided into three categories. One is impaired fasting glucose, one is impaired glucose tolerance, and one is increased A1C. We define impaired fasting glucose as fasting plasma glucose of 100 to 125, and then impaired glucose tolerance as 2-hour plasma glucose in the 75 gram OGTT between 140 to 199. And an increased hemoglobin A1C as 5.7 to 6.4%. Coming to the diagnosis of diabetes, we define diabetes as a hemoglobin A1C of equal to or more than 6.5%, or fasting plasma glucose of more than or equal to 126, and true or plasma glucose equal to or more than 200 during an OGTT, or a random plasma glucose more than or equal to 200. To make a diagnosis, we should have at least 2 of these as abnormal, or if we have only one value, that should have been documented as abnormal at least during twice. Coming back to the case 1, so his diagnosis now is pre-diabetes. He has both impaired glucose tolerance as well as increased hemoglobin A1C. So the next question is how to manage this patient. So we have a well structured ASE algorithm for management of pre-diabetes. Whether it's pre-diabetes or diabetes, the first and the most important aspect for management of diabetic patients is lifestyle modification. It includes both dietary modification as well as encouragement of physical activity. The physical activity should include at least 150 minutes per week of workout, and it should be at least a brisk walking or any exercise equivalent to or better than that which the patient can tolerate. The second important thing which we have to address in patients with pre-diabetes is assessment and management of CVD risk factors, which include dyslipidemia and hypertension. The management of dyslipidemia and hypertension in pre-diabetics is exactly the same as that of diabetic patients. So I'll take up these two things when I come to management of a diabetic patient. The second thing is obesity management. We may consider anti-obesity therapies. For US people or Caucasians, usually we consider anti-obesity medications when the BMI is more than 30. But for Indians, we can consider even when it's more than 27. The third important thing to be addressed is the anti-hyperglycemic therapies. If there's only one pre-diabetic criteria, we can just try to intensify the lifestyle modifications, or you can consider even starting on the medications. The preferred medications for management of pre-diabetics are metformin and acarbose. Well, if some patient meets a multiple pre-diabetic criteria, then we should consider the patient to put on these medications like metformin and acarbose. TZDs and GLP-1 analogs are also other options, but they are less preferred. Coming to the case 2. So a 42-year-old gentleman, he has very symptomatic, he has polyuria, polydipsia and significant weight loss for the last 2 months. His fasting plasma glucose is 268 and postprandial plasma glucose is 380. So how should we evaluate this patient? The initial evaluation of a diabetic patient should aim to classify the diabetes, to assess the CVD risk factors, to detect the presence of diabetic complications, to formulate a management plan, and to provide a basis for continuing care. The medical history should focus on age and characteristics of the onset of diabetes. Younger the patient, more likely the patient to be type 1, especially if the patient's age is less than 20, and more than 30, it's more likely to be type 2. But with the recent change in the age of onset of type 2 diabetics, we have to be a little careful here, because we are seeing quite a good number of type 2 diabetic patients, even in children less than 20 years of age. And those present with DKA are very, very likely to be type 1 diabetes, while those who get detected only on laboratory finding and are completely asymptomatic are very, very likely to be type 2 diabetics. The medical history should also focus on the eating pattern and physical activity habits, and we should also assess the knowledge of the patient on diabetes. The history should also focus on the diabetes-related complications, both microvascular as well as macrovascular. The retinopathy, we should ask for any decrease in the vision or any other visual problems. For neuropathies, we should ask for any tingling sensation, numbness, and history should also focus on any presence of foot lesions, including corns, cracks, calluses, or any ulcers. And the autonomic neuropathy history should focus on sexual dysfunction, orthostatic hypotension, that's giddiness, or any gastroparesis. History regarding the vascular complications should focus on coronary heart disease, cerebrovascular disease, and peripheral arterial disease. If the patient has any dental problems or any psychosocial issues, those histories should also be sought for. The physical examination should include measurement of height, weight and BMI. Blood pressure determination, if required, even orthostatic measurements would be helpful, especially if the patient complains of any giddiness or something. Fundoscopic examination, preferably by a trained ophthalmologist. Thyroid palpation and skin examination for acanthosis nigricans. Physical examination should also constitute comprehensive foot examination, but I'm not going to touch it because Dr. Sabaretnam will deal with this. And the laboratory evaluation should include hemoglobin A1C, fasting lipid profile, including the total cholesterol, LDL cholesterol, and HDL cholesterol and triglycerides. Just getting only total cholesterol and triglycerides are not sufficient. And the other tests that should be included are liver function tests, test for urine albumin excretion, preferably with spot urine albumin to creatinine ratio, serum creatinine and calculated GFR, TSH and type 1 diabetic patients, and even type 2 diabetic patients with dyslipidemia, or any woman over age more than 50 years should also be screened with TSH. So after the proper evaluations, so whenever it's required, we should refer to the appropriate consultants. We may require the help from eye care professional for annual dilated eye exam. We should refer the patient to a registered dietitian for medical nutrition therapy, to a diabetes educator for self-management education, to a dentist for comprehensive periodontal examination, and if needed, we may have to seek the help from a mental health professional, especially the patient has depression, or sometimes the patient may not be ready to accept the diagnosis. If the denial persists for more than a month, then we should seek a mental health assistance. Coming back to the case 2, we know the patient has a symptomatic type 2 diabetic, so how to manage his hyperglycemia is our first question. According to ADA, of course, lifestyle modification is the first and most important, as I said earlier with the pre-diabetes. According to ADA, when we start with the drug therapy, metformin is the first choice because it has high efficacy and there is low risk of hypoglycemia. Frankly speaking, there's no risk of hypoglycemia. And it's weight neutral, or in some patients it may cause weight loss, which is very much useful for obese type 2 diabetic patients. And the side effects like GI tolerance, though common, but they're easily well manageable, especially if you titrate slowly with 500 mg OD to gradually increase at a weekly basis to the maximum dose. And even with the use of sustained release preparations, the GI side effects have come down. And the dreaded complication, the lactic acidosis, though it is mentioned along with metformin, in a healthy patient other than diabetes, it usually does not occur. It usually always occurs on the background of some of the organ dysfunctions like renal failure, liver failure, or cardiac failure. And the major advantages is that it's a low cost drug. Despite all these reasons, the other most important reason why metformin is preferred as a first-line drug by ADA is that the use of metformin is associated with 42% reduction in the CV mortality. That's the reason why metformin is still considered as the best drug, even though many new drugs, even with lesser side effect, have become available. The ADA clearly recommends that whenever you have a type 2 diabetic patient, start the patient on lifestyle modification along with metformin. And it also says that wait for at least 3 months after you have reached the maximum dose of metformin before considering the addition of a second drug, provided the patient is not hemodynamically compromised or not having any some bacterial infection or any other severe comorbidities where a rapid glycemic control is required. So when patient is not getting controlled on maximum dose of metformin, we can add a second drug. It could be sulfonylurea, or could be a TZD, could be a DPP-4 inhibitor, or GLP-1 receptor agonist, or basal insulin. Sulfonylurea have a very high efficacy. The hemoglobin A1C reduction could be up to 2%, but they have moderate risk of hypoglycemia. They may cause weight gain, and the major advantage is that they are very low cost drugs are also available among sulfonylurea groups. The TZDs again have a high efficacy, almost up to 1 to 1.5% reduction in the hemoglobin A1C. They have a low risk of hypoglycemia. They cause weight gain. The major side effects associated with pioglitazone or siglitazone or edema, heart failure, and increased risk of fractures. But the recent controversy with pioglitazone and bladder cancer should also be kept in mind. Though the risk of bladder cancer is only 1 among 500 people who have used pioglitazone for 5 years, still still that has raised recent controversy, so that should be kept in mind. And the cost is relatively high. The DPP-4 inhibitor has moderate efficacy. It decreases hemoglobin A1C by only 0.5 to 1%. And but the advantage is that there is hardly any hypoglycemia reported with DPP-4 inhibitors, and it's quite neutral. And hardly any side effects have been reported with DPP-4 inhibitors. But only the limiting factor is its high cost. GLP-1 receptor agonists can also be combined with metformin. Again, they have a good efficacy. They have low risk of hypoglycemia. The advantage is that they cause weight loss, so it's very useful for patients who have severe obesity. The side effects are sometimes limiting for use of GLP-1 receptor analogs. They cause severe nausea and vomiting. The liraglutide is very high cost, but recently the cost of exenatide has come down. Metformin can also be combined with basal insulin. Again, of course, there's no limitation for the reduction in hemoglobin A1C with use of insulin, so it has the highest efficacy. Hypoglycemia is high, of course, and it may cause weight gain, and the costs are variable. Of course, some costs of some basal insulins are also coming down now. When the patient is not controlled on the second drug, which has been added to metformin with its maximum dose for 3 months, then we can consider going on to third drug. So we can combine any drug with any drug, except for the DPP-4 inhibitors are not approved to be combined with GLP-1 receptor agonists. ADA even does not approve the combination of sulfonylurea with basal insulin and metformin. But in clinical practice, actually this is the best regimen which works very well. When we combine metformin with sulfonylurea, and then along with that if we add basal insulin, the patient will have a better and smoother glycemic control than using only metformin with basal insulin. So when the patient is not doing good in any of these 3 drug combinations, when the more complex insulin regimens using multiple daily doses could be used. But the other authority, the AACE, has slightly some different recommendations regarding the management of type 2 diabetes. It rather suggests management of type 2 diabetes in newly diagnosed patients depending on the baseline hemoglobin A1C. If the baseline hemoglobin A1C is less than 7.5%, it recommends monotherapy along with lifestyle modification. And if it's between 7.5 to 9%, it recommends dual therapy. And if its hemoglobin A1C is more than 9 with asymptomatic, we can still manage only with oral therapy, which may include dual as well or triple therapy. If the patient is symptomatic, along with the A1C of more than 9, it's better to use insulin with or without other oral agents. But in my clinical practice, what I can notice is that don't combine with metformin with the sulfonylurea if the hemoglobin A1C is less than 9%, because those patients are very likely to go into hypoglycemia. If you want to manage 7.5 to 9 with a double drug therapy, it's better to combine metformin with some other weaker agent like a DPP-4 inhibitor or TZDs, which does not have the risk of hypoglycemia. So we have dealt with the glycemic management, but further evaluating the cardiac CVD risk factors and the complications of this type 2 diabetic patient. The blood pressure of this patient is 138 by 90 mm of mercury. Triglycerides are 340 mg per deciliter. LDL is 155 mg per deciliter. HDL is 30 mg per deciliter. And even his urine microalbumin is elevated, 60 microgram per milligram of creatinine. And fundus do show bilateral microaneurysms, that is very early retinopathy. So what are the recommendations for management of hypertension and diabetic patients? People with diabetes and hypertension should be treated to a systolic blood pressure goal of less than 140 mm of mercury. And a lower systolic target such as less than 130 mm of mercury may be more appropriate for younger patients and definitely should be tried to achieve in CKD patients. Patients with diabetes should be treated to a diastolic blood pressure of less than 80 mm of mercury in all group of patients. The treatment should include, of course, lifestyle modification, as I said earlier. Along with the previous lifestyle modification, diet should be encouraged for these patients, which is characterized by low salt diet with potassium rich diet. And a regimen that includes either an ACE inhibitor or an angiotensin 2 receptor blocker may be considered if the patient is not achieving the target goals, only on lifestyle modification. And whenever we start the patient on ACE inhibitor or ARBs, we should always monitor the potassium and creatinine because they are associated with the risks of hyperkalemia and even worsening of the renal functions. Coming to the management of the second CVD risk factor, that is dyslipidemia. All patients who have overt CVD or patients more than 40 years of age who have one or more other CVD risk factor like family history of CVD, hypertension, smoking, dyslipidemia or albuminuria should be started on a statin. Even we can consider statin therapy for all patients who have LDL cholesterol more than 100 mg per deciliter, irrespective whether they have CVD or they are more than 40 years of age. The treatment target for dyslipidemic patients is to maintain a LDL cholesterol less than 100 mg per deciliter if the patient does not have overt CVD. But if the patient has a overt CVD, the target should be less than 70 if it's possible. If not possible, even less than 100 is okay. Coming to the antiplatelet agent use, we have to consider aspirin therapy for all men who are more than 50 years of age or women more than 60 years of age who have at least one additional major risk factor, which include the family history of CVD, hypertension, smoking, dyslipidemia or albuminuria. Earlier actually aspirin was recommended for all patients who are more than 40 years of age, but because of the increased number of hemorrhagic strokes which have been observed with especially for people who are more than 60 years of age, now they have decreased the use of aspirin to only this group of patients. Aspirin therapy should be used for all patients with the overt CVD as a secondary prevention strategy. And for those patients who with CVD but have allergic tendency for aspirin can be treated with clopidogrel. And combination therapy with aspirin and clopidogrel should be used for at least up to 1 year after an acute coronary event. Coming to the recommendations on monitoring and management of diabetic complications, especially the microvascular ones. Coming to the nephropathy screening, all patients of type 2 diabetes should be started on nephropathy screening as soon as the diagnosis. But for type 1, it should be after 5 years of onset of diabetes. The screening should be with spot urinary albumin creatinine ratio. And all patients with type 2 diabetes should also be screened with serum creatinine, and the GFR should be calculated with the Cockcroft-Gault or MDRD formula, and the stage of the CKD should be assessed. And all patients who have a microalbuminuria between 30 to 290 mg per day or 30 to 299 microgram per gram of creatinine or macroalbuminuria which is more than 300 should be treated with ACE inhibitors or an ARB. And these patients also should be managed with dietary modification to reduce the protein intake to 0.8 to 1 gram per kg per day in the initial stages of CKD. In the later stages, the protein intake should be cut down less than 0.8 gram per kg. And we should refer to nephrologists whenever there is uncertainty about the etiology of kidney disease, or there are some difficult management issues, or the kidney disease is advanced when they are about to require dialysis or renal transplantation. Coming to the retinopathy screening, of course the same timing of screening is same as that of nephropathy. And once the normal nephropathy has been documented, it should be screened at least once a year. But if 1 or 2 or 3 normal exams have been documented at annual examinations, we can relax the frequency later on to do only once in every 2 to 3 years. And more frequent examinations may be required if some retinopathy has been documented and it's in a progressing stage. Coming to the management of retinopathy, we should promptly refer those patients with clinically significant macular edema, a severe NPDR or any PDR to a retinal specialist. And laser photocoagulation should be indicated for those patients who have high risk PDR, CSME and some cases of severe NPDR. Anti-VEGF treatment may be considered for patients with diabetic macular edema, and presence of retinopathy is not a contraindication for aspirin therapy. So at the end of this case, the model prescription for this patient should be to advise a proper diabetic diet, preferably by a registered dietitian, physical exercise, at least around 150 minutes of brisk walking per week. I personally, there are so many regimens which I have told, but I personally prefer this for this patient because he was very symptomatic and your hemoglobin A1C would definitely be more than 10. I would like to start this patient on metformin 500 mg twice a day, and simultaneously I would like to start this patient on insulin. So after maybe 15 days to 1 month, once his blood sugars come to the near normal range, we can stop the insulin and we can add the second oral hypoglycemic drug, either DP4 inhibitor or a sulfonylurea. And since he has elevated LDL, we should start this patient on rosuvastatin or rosuvastatin. And since he is also having hypertension, of course we should document that his hypertension is there for at least 2 times at an interval of 1 week before starting the medication. So if it's documented, then we should start the patient on one of the ACE or ALPs. Telmisartan is one good drug which has a long duration of action with persistent effect on the persistent control of the blood pressure. And since he's already having and telmisartan will also help to reduce his protein albumin excretion, which is already has been started with. And ophthalmology reference you will also require since he already has microaneurysms. And depending on his progression, he will require at least once in a year and that retinal examination. Yeah. Thank you so much. Diabetes, of course, a vast topic, so I not covered
Very
everything.
comprehensive review, sir.
Sorry?
Are you
Very
using
comprehensive.
5%?
5% I'm still using. But actually the thing is that currently in India we can use only a 15 mg kind of thing. But initially I was using 30 mg and actually it's one of the very good drugs and even the risk of bladder cancer with pyridoxine is very less. I think it's always just a political game which happened and led to the banning of pyridoxine.
So what do you say, 7.5 is good or 15 is good?
15 is minimum actually. 7.5 when you're using twice a day with along with some other drug combinations, maybe you can use 7.5 twice a day. But 7.5 itself does not have a good reduction in the hemoglobin A1C. So at least 15 will reduce the hemoglobin A1C by 0.5%, which is the criteria for any drug to get approved actually.
But what do you tell your patients? Bladder cancer, once and this thing, how do you defend yourself?
Always there is never a problem, sir. We are never discussing that. But after this issue has come up, we are saying that they are likely to develop. There is an increased risk of bladder cancer, but that's a very less. Only if 500 patients take the drug for 5 years, there is one chance of bladder cancer. We just explain that. Yeah, please.
There is a weight gain with pioglitazone.
Sure.
And if you raise the doses, the patients complain of weight gain, which goes really against the therapy that we are giving. The patients do come, a lot of female patients, I use a lot of pioglitazone, so I have a lot of issues with their weight gain. So the minute I try to go beyond 15, the weight gain goes really rapid.
Yeah, when we use 30, definitely there's a weight gain actually. 15 is the one which usually don't come across this one. But ma'am, rather than the weight gain, the benefit of increasing from 15 to 30 in terms of glycemic control is very good actually. So maybe you have to just balance it while deciding that. The patient doesn't.
Older patient not able to exercise, very hard to have them, they don't listen to diet controls, very hard at an older. Younger patient you can inspire for diet and exercise and get the pioglitazone to 30. But an older patient, it again.
Definitely. Anyhow, in older patients, we are not usually, especially in women, I don't consider madam because even it is worsens osteoporosis and the chance of fracture is also there. So usually I won't consider pioglitazone for a female especially who is more than 45 years of age actually.
Can you tell us the indications for aspirin one more time? Sorry.
Any male more than 50 years, any female more than 60 years with one of the risk factors like hypertension, albuminuria, dyslipidemia, family history of CVD. One more is there.
Yeah.
One more is there.
Smoking.
Smoking.
And what dosage do you advocate?
Usually start at 75. And usually if there's an old CVD, we usually consider 150. Primary prevention 75 usually.
With the risk factors. Lesser with risk factors. What is?
Sorry?
Lesser age with risk factors.
Lesser it's not there. we should not recommend. When earlier actually we had the cutoff of 40 years actually.
Yeah, that's
So
what-
now it has been increased actually. So because the main aim also is like the risk of having a CVD in next 10 years should be at least 10%. So then only aspirin is recommended. For patients less than 50 to 60 years, so even if they have some risk factors, the chance of having CVD within next 10 years is less than 10%. They say actually you can, depending on if the multiple risk factors are present, then the clinician should decide whether to put on an aspirin or not. But there's no standard recommendation that all these patients should be put on medication.
One suggestion is that family history is very important in that case
Yeah.
when you're making a decision on aspirin.
Definitely.
That is
Agree.
one of the most important
Definitely.
histories that should be taken.
So the family history of
Cardiovascular disease. Even if somebody who has a 45-year-old male family history is there, he is a smoker, he has
Comorbid
dyslipidemia, still it's at your level, but you can decide and put the patient. There's nothing wrong in putting the patient on aspirin.
No, I was asking from a personal point of view because my husband,
Okay.
he's 45, he's dyslipidemic.
Okay.
Family history, his father at the age of 78, he had a mild disease. So should
78 is okay, but it's not like a
Yeah.
strong history.
Oh,
If
person-
it's a smoker or it's like he has hypertension or something.
nothing
then
else. He
nothing.
only had dyslipidemia.
Then you can rate him. There's no need for
He's
aspirin.
been on aspirin since I think the last 3-4 years.
It's okay.
Probably that 2008 guidelines were recommending it, and probably that time he must have been started.
Okay, then I'll ask him to stop.
He'll be confused.
At what age, with all the risk factors, with all the risk, family history of risk CVD, hypertension is there, he smokes, he has dyslipidemia, and he has got also albuminemia. So, if he has all this below 50 years, should we start aspirin?
If he has more than 3 risk factors,
Oh.
even if it's less than
50 also
50,
you
it's better you can consider.
Thank you.
Thank you so much.
Thank you very
Thank you,
much.
sir.
I'll be talking on surgical management of diabetic foot. Any surgeons are there in the audience? Anybody? Any surgical colleagues? No, I think so. Okay.
Local surgeons.
And this it is only it will be overview. I'll not go into the details of management or surgical aspects. And when Vijay gave the last prescription, I was eagerly looking whether he had put the podiatric consult or this one. Any diabetic foot surgeon consult, it was not there. That's the state of India. Yes, diabetic capital of the world, and even diabetic foot capital also. And I do not have questions like him to ask you people, so you can be happy. But I have one question. Anybody knows who is Elizabeth Taylor?
Yeah, she's married many times.
Yeah, and she used to tell all her life partners, I will not keep you for long. And I am going to do the same thing. I will not keep you for long. Your patients are waiting. And just coming to the epidemiology, like 15% of all diabetics during their lifetime will have diabetic ulcer. And 15 to 20% of these ulcers will need amputation. And in India, 85% of amputations are due to diabetes. And this is a rough estimate. They say around 40,000 to 50,000 amputations in India due to diabetes each year. And what's the rule of 15? 15% of diabetic patients will develop ulcers, and out of these 15% of ulcers, they will result in osteomyelitis, and 15% of these ulcers also will result in amputation. So you can imagine the load of these diabetic foot in India. And this is a basic slide. Like wound healing, we all know there are 4 stages of wound healing. First is a coagulation phase, inflammatory phase, proliferative phase, and a maturative phase. And in diabetics, the wound healing is stuck at the inflammatory phase. And as Dr. Vijay said, neuropathy is one of the most important factors. There is a loss of protective sensation, and there is a autonomic dysfunction with impaired neuroinflammatory reflex. There is macrovascular disease also, as well as microvascular disease, abnormal cellular pathways, and excessive inflammation. These are the things which play a major role. And as I said already, peripheral neuropathy resulting in decreased perception of pain, temperature, and proprioception, with small muscle wasting, which leads to foot deformity, and there are increased plantar pressures. And autonomic neuropathy also results in decreased sweating with dry skin, which results in callus formation, and as well as peripheral arterial disease. These all together, and most of the times trauma is the initiating event. And coming to the general foot examination, like most of the times, most diabetologists, I do not know how many percentage they examine the foot, and in American Diabetic Association and Canadian Diabetic Association, they recommend at least foot examination in the first visit itself. When the patient comes, like inspection is carried out, and then you palpate for the blood vessels, especially the posterior tibial and the dorsalis pedis artery. Then you look for the con, callus, bunion, prominent metatarsal heads, hammer toe or claw toe, whether there are any cracks, fissures, whether absence of hair suggesting peripheral vascular disease, whether the nail is thick, ingrown, and interspace maceration is there, any fungal infections and ulcerations. And here you can see a callus in the first figure, and second shows a muscle atrophy, third the prominent metatarsal heads, and fourth the heel cracks. And at least neuropathy examination, supposedly we are supposed to do the Siemens-Wilson monofilament test, or if there is available biothesiometry, and this one ischemia evaluation in the form of ABI, ankle brachial pressure index, with the handheld Doppler if available. These two tests at least. And based on this, we can classify the peripheral vascular disease as normal, mild obstruction, moderate obstruction, severe obstruction, or a poorly compressible vessel. And coming to the diabetic foot ulcer classification, if you go through any of these journals, you will find this word, Wagner-Magid classification. It's a very old classification. Still, this is followed in many studies, which classifies the foot ulcers into grade 0, grade 1, grade 2, grade 3, and grade 4, grade 5. And grade 0 is the pre-ulcerative stage or the foot at risk stage, where we can prevent diabetic foot ulceration. And now there are different classifications. One such as depth ischemia classification, which takes into account the depth of the ulcer and the ischemia. But this is also not universally followed. Now the University of Texas classification, which takes into account the depth, the ischemia, and as well as the infection. This is the widely followed classification. And coming to the types of surgeries, it's from anywhere from incision and drainage to exploration, debridement with revascularization procedures and amputation. I'm not going to the details of it. The first thing is, like, as a surgeon, you should not do any harm. And most of the times the wound, it's complex wounds, and it's frustrating both for the physician, treating surgeon, as well as for the patients. And we try to involve as many people as possible. That's what I wanted to say. Like, involve as many, this one, like, and most of the times if you do an amputation, make sure the patient goes with the prosthesis home. Those 2 points very important. And it's previously it was thought diabetic foot means radical debridement. Now it's always limb saving approach is there. Not to do a radical surgery, but to do a dependent drainage and remove whatever bacterial and necrotic soft tissue is there. Then we correct the deformities and try to prevent a major amputation. And debridements, now the recent debridements, like you must be seeing in your practice, like they come with the chemical debridement in the form of collagenase and streptokinase. Those ointments are available, but the biological larva and those things are only for academic purpose. And best debridement is a surgical debridement. Regular debridement is needed. And now we have advanced dressing techniques with advanced healing products like growth factors, both platelet derived growth factor and as well as the epidermal derived growth factors. Both are available now in India. So those things are there. And most of the times when we do the debridement, we make sure that, like, we try to convert a chronic ulcer into an acute one, so that there is like it heals from outwards inside. And it's this one, it's very important because diabetic and ulcer can be either can be neuropathic or neuroischemic. The management is different. And in neuropathic ulcer, the foot is warm, the pulses are present, it's usually on the plantar aspect. And in the ischemic ulcers, it's on the margins where you find a cold feet and pain will be, they will have severe pain. And most important thing is mechanical control is like how to redistribute the plantar pressure evenly. And that is by giving what is called as offloading. Offloading, there are many methods like total contact, Scotch boot, like crutches, wheelchair, but still in Indian unaffordable patients, if they cannot afford all these things, bed rest still holds good. And for ischemic ulcers, revascularization, if possible, can be done. And this is how a total contact cast is made. Nowadays, ready-made contact casts are available. Actually, you see an ulcer which is debrided, then it's padding, then you give a plaster of Paris cast. And removal cast workers are also there, which are lightweight, but compliance is poor. Patient will move the part and ulcer will not heal. So this instant total contact cast is available. This has got better compliance with faster healing. And if at all they have a 4-foot amputation, we can give these half shoes. But they are difficult to walk. And I'm not going into the details of dressing. There are interactive dressings are available, or bioactive dressings, like hydrofibers, hydrocolloids, hydrogels, and this is how we decide. Based on the type of the wound, we decide what dressing we should. And coming to single slide about amputation, we try to now, previously the length of the amputated part, like below knee means 12 centimeters from patella, it was fixed. Now we try to keep as distal as possible, give as much length as possible, and that is the one thing. And coming to foot at rest, like if any patient comes, diabetic patient, then you see the patient, check whether the patient has got any neuropathy or angiopathy, then whether deformity is there, callus, edema, and if they have other comorbidities with poor vision, neglect, this one, obese and ignorant patient, these are considered as foot at rest. Then we have to have a prevention. How to prevent these diabetic ulcers? Like we tell the patient to control blood sugar, avoid smoking, then avoid heating pads or hot water bottles near the foot, then trim toenails, and not to trim so much that they cut the edges of the nails, like, and never they should open the blisters, and always they should daily inspect the foot, daily morning, and they should use a mirror if vision is impaired, and they should never walk barefoot, and they should, even if they are wearing a new footwear, they should wear for one hour, then they will have to inspect the footwear whether there are any changes, and they have to palpate the footwear also and see. This is very important prevention aspect. And these are the parts of the footwear, because just like to advise the patient, the toe box should be broad and wide in a diabetic footwear. When you are advising a patient, always advise a patient not to have a small toe box, like narrow toe box. It's a broad toe box with a well padded heel should be there. That's why I put this thing, and never like a high heel or this one. And now ready-made insoles also available, custom made based on the pressure measurements. So those should be used. And whenever we are asking a patient, if a patient wears socks, then seamless socks are available, cotton socks, which should be used. And so to conclude, everything now, most of the things are available. Don't use everything, individualized to your patient, and that's where we prevent the foot ulcers. I put this slide, thank you very much, and these are the things we do as endocrine surgeons. These are the surgeries. Thank you very much.
In debridement, the use of hydrogen peroxide, what is the experience?
No, actually, the hydrogen peroxide is a chemical agent. That's chemical debridement, actually. If you have an unhealthy tissue with what is called like slough, then you can use hydrogen peroxide. If it is adherent slough, then hydrogen peroxide will not. Then you do a mechanical debridement, then you can use hydrogen peroxide.
And continuous use of hydrogen peroxide is not recommended.
Not recommended.
Because it impedes the healing of the.
Not continuous, just one. If it is a dirty wound,
too much of slough is there,
and too much of dust from the, it's a recent wound. If it has come,
Yeah, and one more thing, why we use hydrogen, where it is used is like we do a debridement, minor ooze will be there, small bleeding. Hydrogen peroxide is hemostatic also, because of that we can use that.
But regular use is not required.
Regular use is
Only
not
once.
recommended.
What is your view on this drugs for peripheral arterial disease like silostazol and Daflon, Frental? What is your view on these drugs?
Like if it is started early in the course of the disease, then they might have a role. If it is because these most of the times the medium vessel disease, it involves long segment of vessel, so mostly these don't act. Actually, it's all additive, like what we can say. There are many studies which have found like if started early, then these things work.
Silostazol is the only drug which is evidence-based.
Evidence-based.
Other two drugs are just tried but not much of evidence. Especially if there's if you want to improve the claudication time, silostazol is very useful. But otherwise, ischemic, if the ulcers are there, none of these drugs work.
There's one more drug for neuropathic also which they use, I think some Epiralat with vitamin B12.
B12 and pregabalin, many.
No use. So surgery is the only answer to this.
Prevention of neuropathy first. That is the thing. Like he will say, like if you have good glycemic control, then neuropathy.
And offloading is the most important thing. If you offload it properly in the neuropathic foot, they usually heal.
These are available now, sir. This offloading, this one is available in Bangalore also.
Where do you get them?
Like this one, Bangalore-based, some 3-4 Bangalore-based diabetic companies are there. Like if you want, they'll come and give it to the patient in their house itself. Even preventive footwears are available, where they check their plantar pressures on a Harris mat and then they deliver the footwear with foot care advice and set to see that mirror and that all these nail clippers, everything is there in that thing. So those things are really helpful. All these patients should have a.
And how expensive are these?
Footwear ranges anywhere from 300 rupees to 3000 rupees. So it's very affordable. And this set will cost around 500 rupees. Amputation costs around 32. It's like
Not just
amputation and the psychological thing.
Well, what's your view on this phantom toe, phantom limb and all that post-surgery?
Many patients have, sir, because once we do an amputation, yes, especially also like we do a modified radical mastectomy also, they have this sense that that body part is always there, and that is very difficult also. That leads to so many psychological things. So what, like psychological counseling also very important. In Vydehi we have that psychological counseling also, counselor available. But in Indian setup, it's less when compared to abroad. This phantom. We try to explain now. We always try to explain to the patient. Amputation is the last resort. Now it's all limb saving thing. Previously it was thought diabetic foot means do a radical debridement. If toe is there, remove till the ankle. If the ankle is then do a below knee. Now it's always so many other things. For the want of time I will skip. Like vacuum assisted dressings are there, and hyperbaric oxygen therapy is there. All these things are come in a big way. And now try to, as much as possible, try to preserve whatever food is possible. Preserve, that will give. Now these processes also can be modified according to any.
Thank you very much.